Hello, everybody. Thank you for asking me to speak on the National Lung Cancer Screening Program and the perspectives from HRICS. I'm sorry I can't be with you in person today. I'm actually will be attending Cancer Australia Advisory Council meeting, which clashed at the same time. So I recorded this yesterday on Wiradjuri country. So I pay my respects to the traditional owners of the lands on which we're meeting today, wherever you are watching this from. So the National Lung Cancer Screening Program was launched on 1st of July this year, so 6 weeks ago. It aims to achieve better health outcomes for Australians through early detection, reducing deaths from lung cancer. So why do we need to screen for lung cancer? So although it's the fifth most common cancer in Australia, uh, it used to be higher, but with the reduction in smoking, particularly in men, it's now dropped down the table of most common cancers. But unfortunately, it's the leading cause of cancer mortality in Australia, accounting for some 9,000 cases per year. Lung cancer is more treatable when caught early, and when screening detects the cancer early before symptoms appear, it's hoped that that will lead to improved survival, improved quality of life. So you can see in this graph in different colors are different stages of the lung cancer. So if you have a stage one lung cancer when you're diagnosed, you do pretty well. But if you have a later stage, you do particularly poorly. It's estimated that the screening program may result in an increase in stage one cancers from the current 16% to 60%, and the proportion of stage four cancers will drop from half to about 11% through the screening program. This slide shows what we call a meta-analysis published by the Cochrane collaboration. This was done by a group of Australian investigators where they analysed the results from all of the individual trials in lung cancer screening. And it shows in this diamond at the bottom that the results of the screening trials put together favours the low dose CT scan as a screening methodology for lung cancer. So in the largest trial conducted in the US, which included some 52,000 patients and published in the New England Journal in 2011 by Aberley and all, it showed that there were 247 deaths from lung cancer per 100,000 person years in the low dose CT group, and 309 deaths per 100,000 person years if chest X-ray was used as a screening method, which represented a relative reduction in mortality from lung cancer with low dose CT screening of 20%. It's estimated that for those undergoing at least one screen, the number needed to screen to prevent one lung cancer is about 320. It's also estimated that screening for lung cancer with low-dose CT would cost about $81,000 per quality life year gained. So if this was a pharmacological intervention, like a new drug in cancer, at that cost, this would probably be approved for use as well. So in other words, quite a cost-effective way of screening the population. Sorry, I'll just go back one. Here's the eligibility for the screening program. It's based on four factors. Um, Patients need to be between 50 and 70 years of age. They need to be asymptomatic with no signs or symptoms of lung cancer, currently smoking or have quit in the last 10 years, and also have a history of cigarette tobacco smoking of at least 30 pack years. So these are quite what we'd consider quite heavy smokers. So 30 pack years means someone who smoked a 20 cigarette pack for 30 years. So it's not someone who casually smoked in their late teens or early 20s, but really someone who's smoked for quite a prolonged period of time or at quite a heavy level. And so if people have these overlapping criteria, then they're eligible for lung cancer screening, which is two low-dose CT scans, which are provided free under the NPS system. This is a fairly complicated slide, but it shows the whole screening program on a page. So firstly, there's an element of promotion and awareness, which is ongoing now through both health professionals and to the public. Here's the screening eligibility, as we spoke about, 50 to 70 years of old, no symptoms, currently smoking or quit in the past 20 years and more than 30 pack years. These are similar criteria to what was used in that large North American screening program. Patients can then be eligible for screening or not eligible for screening. If they're not eligible, it's suggested that should be offered smoking cessation support. And there's quite good evidence from the previously conducted screening programs that there's a higher rate of people quitting smoking if they have screening discussed. Patients, if they are eligible for screening, can then be recruited. It's really a GP-based program. So the GP discusses with the patient about whether they want to undergo screening. The GP completes the CT request form, which is registered on the National Register. Patient undergoes screening with a low-dose CT scan. These are much quicker CT scans than we use in a normal diagnostic process. So there's no injection of any contrast. So patients are able to be put onto the table to have the scan and off again in much quicker. So there's quite a higher volume throughput. The scan is assessed with accredited radiologists, and then they use a structured reporting system to look at the lung nodules and do a structured report. And then the National Cancer Screening Register is also responsible for notifying the patients and the GP, and also for the recall system. So there's a suggested pathway for managing the nodules according to whether they're very low risk, low to moderate, high, etc. And so if someone's a very low risk, they're invited to have further screening, low dose screening scan in 2 years' time. But if they have a higher risk, they may be asked to do so in 12 months, 6 months, or 3 months. If patients have a higher risk or very high risk nodule, they're referred to a respiratory physician or another member of the lung cancer multidisciplinary team. If a lung cancer is confirmed, they're treated according to the lung cancer optimal care pathway. If none's found, then they return to the screening program, which may be a 2-year screen. And we'll talk a little bit about these actionable additional findings, which is an issue for this program. So this is a paper, again, some Australian investigators published in the Medical Journal of Australia this year, led by Asher Bonney. And this was from the Australian and Canada lung cancer screening trial. There was 4,400 participants. There was incidental findings found in 73% of those participants, including findings requiring clinical attention in 10% of people. The most frequent of these were coronary artery calcification and emphysema. And there were other lung, cardiac and thyroid problems identified as well. So in the 2,000 Australian participants, 67% had coronary artery calcification on the low-dose CT scan with no prior history of coronary artery disease. 28% of those had moderate to severe coronary artery calcification. They were mostly males, and half of those were currently smoking. The majority of those had high risk or intermediate risk of a cardiovascular event in the next 5 years, and 21% were re-stratified to a higher cardiovascular risk group when this coronary artery calcification was detected on their low-dose screening scan. So this is an important issue, and so not only will patients be identified who may have high-risk lung nodules, but they also may be identified as having potentially other significant lung or cardiac issues that require workup. HRICS has played an important role in the rollout of the program locally. I'm proud to say HRICS has taken on a leadership role in the early days of our awareness of the rollout of the program in developing a coordinated whole of system response. We did some data analysis based on the national modelling that was released. We've helped with preparedness of the region for the program, including making providers and other stakeholders aware of the program and mapping current referral pathways both within and out of the region, and providing a role with ongoing engagement of member sites and other key stakeholders, including the PHNs. This is some graphs showing some local modelling of expected numbers based on the national modelling done by Flinders University in Adelaide. The green is the East Hume populations, and the blue is the West Hume, and the three different categories for 25, 26 and 27. So the modelling suggests that in the East Hume, about 3,200 people would be eligible for screening this year, and 1,800 in the West Hume. There's some rather, I personally think, some quite heroic assumptions in the national modelling, that some 80% of individuals who are eligible will undergo the low-dose CT scan. That'd be fantastic if we get to that 80% level, but based on the uptake of the bowel cancer screening program, the breast cancer screening program, I think we may struggle to get to 80%, but we'll see. It's estimated that in the East Hume and West Hume, there'll be 59 and 30 patients respectively that would need to be referred to discussion at a multidisciplinary meeting, but ultimately about 17 and 9 lung cancer cases identified in the first 12 months. So adding an additional burden to the system, but hopefully these will be a higher proportion of people with stage 1 and 2 cancers that can be cured with early intervention. The number of people with incidental findings is quite substantial, so by a factor of almost 10 compared to the number of lung cancers detected. And here's the numbers for, again, East Hume and West Hume. So all these people, some will have significant findings that will need to be further worked up. There are a number of risks, but also potential benefits to our rural and regional communities. One of our problems, of course, is a lower number of GPs in the region compared to metro. And we have some issues about access and needing to travel to radiology practices for the low-dose CT scan. And in general, we have lower rates of health literacy compared to metropolitan populations. But some of the perceived benefits is improving the equity and access issues through a coordinated response, through some nodule clinics and mobile vans, boosting the community trust and engagement with preventative health services, with the opportunity to discuss quitting and addressing other health issues if incidental findings are made. There's an opportunity to implement culturally appropriate pathways to better support Aboriginal and Torres Strait Islander people, and ultimately, hopefully, reduced hospitalisations and treatment costs through these earlier interventions. In response, the Victorian Department of Health has announced 13 public health services across Victoria, which will have lung nodule clinics to improve access to the downstream management of the high risk nodules. Um, there's a proposal that Golden Valley Health will partner with St Vincent's Hospital in developing a lung nodule clinic. Unfortunately, at this stage, it looks like Albury Wodonga Health has missed out in funding for a lung nodule clinic. One of the important initiatives of the program nationally is the development of some mobile CT vans. So Heart of Australia is a philanthropic organisation that will be tasked with managing these vans. There's 11 vans in total planned coming online in 2026, and they're aimed at servicing rural, remote and First Nations community and taking these vans out to remote places where people can have their low dose CTs rather than having to travel into bigger centres. Importantly as well, there's been quite a lot of focus on ensuring that our Aboriginal and Torres Strait Islander communities are considered in the implementation of the program. Unfortunately, lung cancer is the leading cause of death now in Aboriginal and Torres Strait Islander people, who are 1.9 times more likely to develop and die of lung cancer compared to non-Aboriginal Australians, including according to the Australian Institute of Health and Welfare Studies. So the National Aboriginal Community Controlled Organisation has been co-designing a program in partnership with Aboriginal and Torres Strait Islander communities and their ARCHOs to ensure that a culturally safe, equitable and accessible program is developed, including the development of a whole number of tailored information materials and educational resources, implementation strategies, clinical guidelines, communication tools, to really try and ensure that the particular needs of these communities are considered. There's now lots of resources for both community members, excuse me, and our health services and stakeholders to utilise, and some of those websites are listed here. So there's plenty more information available, and that's being updated continuously. So the National Lung Cancer Screening Program is set to save lives in the years ahead as the program starts to roll out. HRICS are playing a role in providing information to stakeholders, supporting stakeholders to identify and address gaps, and helping to ensure equitable access to the program and access to downstream services. It's assisting in service redesign and really ensuring that regional voice is at the table at a state and national level as the program is rolled out. And there are now many resources available to assist in the implementation of the program. So thank you very much for listening, and enjoy the rest of the forum.